I now want to introduce Professor Mark Yates, who is Associate Professor and Director of Clinical Studies at the Ballarat Clinical School, Deakin University. Mark's areas of clinical interest include dementia, memory disorders, continence management, airways disease, and healthcare delivery in an ageing society. His focus is dignity with care and driving a national awareness campaign on identifying and managing those who are affected by dementia. Would you please welcome Professor Mark Yates.
Thank you very much, and Catherine, thank you very much for this invitation. It's a bit daunting being up here. There's 700 of you down there and I'm alone up here. So I hope you're going to be friendly, and I hope I have the opportunity to share some information with you all, because, you know, we know a lot about dementia, but there's still a lot I don't know. And so if there's stuff that you don't know about dementia, then you're not alone. And this next 35 minutes, I'm really hoping that you don't feel that you haven't had a question answered. So when I've spoken with carers before, and I absolutely adore this role, and people with dementia and other health workers, it's because as a doctor in this space, I actually get to really understand what is the concern of my patients and those who are caring for them. So I'm hoping along the way, and there's a couple of floating mics, that you're going to ask me some questions. I've got a few slides, and hopefully we'll end up answering those questions. Because if you've come here with a burning question and you leave having not had that question answered, then I think we've failed. And there's an opportunity at the end of the day also to do that as well. So we're going to start with Fossey. Fossey's not alone. If you look right at the back, there's Abby in the back corner. But these are my cows in Buninyong in Ballarat. And Fossey's there to just remind me about where I am along in this talk. So it's my memory prompt. So I think we might try and get started. And I think the first thing that people have asked me about in these sort of forum, and I hope you're thinking about a question because I'm going to come and ask you, is about what is dementia. And before answering that question, and you've got some answers up there, it doesn't matter, how many people here are health professionals working in the field? Okay, so we've got a fair number, so I'm just trying to work out how to manage the sort of way I talk about stuff. How many people are family members looking after someone with dementia or someone with dementia themselves? Excellent. We've got a near majority of the real people in the audience, the people who really matter, which is so important. Okay, so I often get asked about, well, what's the difference between dementia and Alzheimer's disease? Is that a sort of useful question? So I'm going to start with this idea of dementia. And often it's used in medical terminology as a diagnosis, but I want to be absolutely clear that dementia is not a diagnosis. It's just a term that we clever doctors use, because we like to have smart language to make it look like we know something. That describes memory loss and impairment of at least one of a variety of cognitive domains. It's thinking domains. So let's put it, it's not a diagnosis. And more importantly, it doesn't indicate severity or level of function. And this comes back to issues of language. I find it distressing when my residents use the term, oh, Mrs. So-and-so in bed 21's demented. I go ballistic. Is she cardiac failured as well? And diabetesed? Because the term demented presumes a single outcome, that they're no longer a member of the community. There's only one paradigm. That is, you're demented or you're not demented. Well, is there one paradigm for cardiac failure? I mean, some people with cardiac failure will take their water tablet, pee for a couple of hours, and then go and play 18 holes of golf. And others are in a wheelchair. So cardiac failure can be severe or mild. Dementia can be severe or mild. To assume, to label someone as being demented just assumes that there is a single paradigm. So it's not a diagnosis. It doesn't indicate severity. And more importantly, it doesn't indicate prognosis, because there's a very wide prognosis being what's going to happen in the future, which is a very important question that most families and people with dementia want to know. But depending on the underlying cause of the dementia, then we can think that determines what the prognosis is. So if we're going to think about dementia, we need to think about the other cognitive domains. And I really want to take you through this in some detail because it's relevant to the rest of what we're going to think about in relation to dementia. So, aphasia. I don't know whether you were brought up. When I learned this as a medical student, aphasia meant no language at all. Apraxia meant you couldn't do anything. Agnosia meant you couldn't recognise anything. And I thought, well, this is going to be an easy diagnosis. But what I didn't know is, and this is no disrespect to our international guest speaker, is the Americans see things in black and white as opposed to the Europeans and English. I was used to dysphasia. But any abnormality of language is an aphasia in this language, which is developed under the DSM criteria. So language problems are the sorts of things, in fact, that we've just heard about, this difficulty in finding the right words that you want to say. How many people here have had an experience where they're working with someone with dementia who sort of says, oh, I want to get the, it's going to keep me warm this afternoon when we go out. We've all had that experience, and what were they talking about? A coat or a jumper or something. And that's what we call circumlocution. That's this difficulty finding words we want to say, and how frustrating that must be. And for those who want to know, I've made these slides available, so I'm very happy for them to go up on a website. So save you having to write notes or take photos. Hey, take photos, it doesn't matter, but they're there. So thinking about that, and I'm going to come back, this is where it's relevant. It's relevant to this whole concept of how we develop a dementia-friendly community and how we actually make dementia-friendly hospitals. What about apraxia? Well, apraxia is the ability to carry out purposeful movements, even though there's no sensory or motor impairment. And this is a real frustration. How many people often I look at, get someone to come in. I'm working in Ballarat. There's lots of farming community here in Ballarat and in Bunanyong. And I'd be very surprised, and I'd be concerned about one of my senior farmers who's, very fit and healthy and strong otherwise. And yet he comes in a pair of tracky dacks and a pullover jumper. I'm thinking, that's not usual, because most of the farmers are in their pork pie hat, their braces, their tie, and the whole works. And you wonder why that's the case. And is it because they don't care? Of course not. What is it? What's the problem there? It's getting all the clothes on. I mean, older women, ladies who have enormous difficulty. You wonder in the heat of the day. There are all the problems with chafing in all sorts of awkward areas, but getting around here to get all the sort of apparatus on is extremely difficult. And I've watched a number of ladies who actually around here, and then you get the business. And it's really important. This is addressing apraxia, and it's a frustration. Thank goodness, innovation has been good. How many bras now do up at the front? There's lots of them, really handy. Let's not say things aren't important. So that's an apraxia, and if you want to experience apraxia, how many gentlemen are in the audience? I don't know. I've got these great big bushy eyebrows, and trying to trim my eyebrows one day in the mirror was really almost a point of complete blindness, because I almost poked my eye out 3 times. Because trying to get something going in the mirror when you're looking in the mirror is impossible, isn't it? You move your hand in one direction. Ladies, you don't care. You don't know this because you've never really, unless you've learnt how to work in a mirror from the day you were sort of, 10. Mind you, if you saw the 6-year-old who got mum's lipstick, where does it end up? From here to here. Why? Because they are dyspraxic. They are apraxic in a mirror, because where you want to put your hand in one direction, it goes in the opposite direction. How frustrating is that? So if you've got a cognitive impairment, you've got dementia, and you can't get your hand to work in the direction it wants to go, you then stop doing things that are important. Maybe it's the embroidery that Anne mentioned. Maybe it's getting dressed and putting that brooch on. One of the classics is 35 degrees, and there is Mrs. Jones with a great big coat on. I'm thinking, why do you have your coat on? And the daughter said, but Mum loves the brooch. Getting the brooch off one coat and putting it on a different coat is just too hard. Agnosia.
Agnosia is the difficulty. You think about it, you can't recognise the nose in front of you. That's how I remember the word agnosia. But it's difficulty recognising things. How difficult is it in homes to recognise things, to find familiar objects? Who's had an experience where they can't recognise something and then someone said, here it is, the boy's look? I mean, both I'm accused of a boy's look. How many people here have got a drawer from hell? In the kitchen, come on, right. And in there is that drawer that, you know, is all the everything you never really want to use. The prawn deveinner you were given as in Christmas stocking and, you know, and the sausage maker. Now, I was making spaghetti bolognese. And I was in a desperate hurry because I had the onions going and I'd forgotten to crush the garlic, you know. You can't start a bolognese without some garlic fried in as well. And I couldn't find the garlic crusher. I got crosser and crosser and crosser. Until my daughter goes, here it is, Dad. And it was right under my nose. And why? Because my wife had bought a new garlic crusher. And I was looking for the garlic crusher in my visual image of the garlic crusher I was looking for was my old one. It was a beautiful old garlic crusher. I don't know why my wife threw it away. You know, a bit of garlic, a bit of white enamel, all in together with the bolognese. It was fantastic. Anyway, it was red and it was a different shade. Now, I know what a garlic crusher looks like. We all know what a garlic crusher looks like, but that wasn't what I was looking for because that was where my visual memory was. And if you have difficulty with you're trying to remember items and look for them and they're all cluttered, it's quite difficult to find. One of the tests, how many people here are in residential care? So if you use the PAS, there's that drawing of a kettle with a fork and a pair of scissors over the top. Well, that's about recognition. And when there's a whole lot of clutter, you can't recognise an object. So if in fact there's the table and it's covered with things, you can't see it. So I mean, if I have a set of glasses and you've got a newspaper over the top, anybody will say that's a set of glasses unless you've got agnosia, because you can't complete the picture. And then, oh, it's such a frustration. There it was, right under his nose. And he always asks me where his glasses is. Well, you know, that's about agnosia. And disturbed executive function is much more complex. That's about planning and organisation. And we thought about abstract ideation. And that's a very weird term. I never really understood abstract ideation. But it's really that ability to imagine something, to think out aloud. So who can imagine a cube? If you think about a cube now, how many sides can you see at any one time with a cube? 3, about 3. And you look at it, yep, and you know that there are 3 other sides. Now, if you've got short-term memory and abstract ideational problems, not only are you not going to be able to imagine that there are 6 sides to this particular cube, you're going to look at 3 sides of the cube, and then you're going to turn it over and, oh, it's a different cube. That's problematic when you're trying to solve a complex problem. And problem solving sits within this executive function area. So if, in fact, one daughter comes along to say, Mum, look, the nursing home's fantastic. You know that Marjorie lives there and you've been a bit lonely at home, and you say, Mum says, yeah, that's a great idea, I want to go to the nursing home. And the son comes along and says, Mum, you can't take Jack the dog with you to the nursing home and the food's a bit dodgy. Oh no, I don't want to go to that nursing home. And then what do you get? You get conflict. And that happens because of disturbed executive function. It's not that that person or that lady wanted to have conflict within a family. It really comes about because of this inability to follow a complex plan. And another component of the executive function problem is this ability to empathise. And this is quite distressing, isn't it? I mean, you as a carer, and it happens in the hospital system. I work with nursing staff who are always stressed, and they really do expect their patients to understand them. Oh dear, you've had such a busy day. I've heard that you had 2 rest calls and there's 3 people come in from theatre. I can see that you're really stressed. Just sit down and relax. You just come and look after me, but I'll relax you while you look after me. Well, that ain't going to happen. If you've got executive and problem-solving difficulties, you actually respond to the emotion that is coming to you. You do not. You have a very great difficulty abstractly thinking, why is this person so cross or stressed? Realising then that that's because they're very busy, and then having to respond to how to help them calm down. That ain't going to happen in the setting of executive function. So, and I'm just going to put this slide up. So this is the, is it dementia, is it Alzheimer's disease slide. Who's confused by that? Nobody. Excellent. There's a few people who's waiting. So I'm actually, often I'm told, I'm so glad you told me it was Alzheimer's disease and not dementia. Or I hope you tell me it's dementia, not Alzheimer's disease. Well, the way I discuss this is that dementia is like saying trees, and Alzheimer's disease is the gum tree. It's the most common cause. It's the most common tree in the bush, and it's the most common cause of dementia. It's probably about 50 to 70% of all, depending on age groups. I haven't got frontotemporal dementia in there, but vascular brain injury or vascular dementia is probably the most common. And then there's Lewy body disease, which we've just heard about, and frontotemporal dementia. And if you look at this, there's a lot of overlap, isn't there? And that makes it very hard for us as docs. We like to think we know everything and we can be perfect, but we can't. And we sometimes can't pick a dementia early on as to exactly what the cause is, and sometimes it becomes clearer later on. So are there burning questions? Because I'm going to go through some other stuff, and if I haven't answered your question at the end of my talk, it's going to be problematic. Oh, nobody's game. Yep. There's one up there.
So if you only have like the memory loss and maybe none of the other diagnoses, or they fade in and out, is there another reason for your memory loss? Or?
Okay. I'm very glad you've asked that question, because we're just going to talk about cognitive impairment. How did you think I'll pay you later on. So we often talk about cognitive impairment. So we've talked about dementia. We've talked about that Alzheimer's disease, Lewy body dementia, and all those sit under that group. And then there's another idea called cognitive impairment, which is even broader. It's a great big umbrella that captures delirium and dementia, and that has all of these various different areas of potential abnormality. But what actually was asked here was about, is about this particular point. What happens at this inkling of change moment? What happens when there's just a little bit of change, but doesn't have everything else? I think that's really what the question is. And this is around this question of when is it dementia and when is it not dementia? When are those symptoms enough to make the diagnosis of dementia? And to be honest, we just draw a nice fat line, well, a very skinny line in the sand, and then we pretend we actually know what we're doing. And we actually, it's pretty hard to define this. And, you know, I've got an international expert with me in the audience, and I'm going to simplify this because there are ways to try and separate it out. But at a practical level, when you get the inkling, and I think this is where families can feel very lonely. I mean, I'm sure there are people in the audience here who have struggled getting to the point, knowing that there's a problem, and having to wait and wait and wait and wait until the problem can be actually sorted out, and then finally the aha moment happens. The average time from symptoms to diagnosis in Australia is 3.1 years. Is that good? I don't think so. Could it be better? Yes, it could. So this area of inkling, this is sort of this when you first feel that there's a problem, is around there's symptoms of repetition, poor recall of events and appointments and plans. And there's personality change as well sometimes. And sometimes you can get one of these without all the others. And we describe this as mild cognitive impairment. So it sounds another really fancy word, but it's where we don't know whether it's someone's between, it's not quite normal because there are real symptoms that the patient's providing to us, but at the same time, it's not yet dementia. And why is it not yet dementia? It's because really, in fact, even though the concerns of memory, and they're measurable but very mild, on a day-to-day basis, people are doing all the things they want to do, okay? And we can break mild cognitive impairment up into two sort of areas. One is we can say it's amnesic, or it's related mostly to memory. So this is a pure memory problem, but everyday stuff seems to be working. Still driving, still doing a bit of the banking, still shopping, still baking for the RSL, and still doing the knitting. So we might call that mild cognitive impairment. And the population with mild cognitive impairment are higher risk to going on to having dementia, in particular Alzheimer's disease. And under the new guidelines, which I think Maria's going to mention later on, we would now, in our clinics, want to review anybody with mild cognitive impairment at about a 12-month interval to see whether there is any change. And what we do know is about 19%, or about 1 in 5, go on to develop Alzheimer's disease each year. So it's pretty good. I mean, I like to turn it around. 4 in 5 chance of not having Alzheimer's disease in the year. So it's not a major problem, but it's an area that's rich for us in research and therapeutics, because if in fact we can treat this so that there is less likelihood of going on to develop dementia, then in fact we'll be on a winner. So, and this comes back, I wanted to briefly mention then this concept of the double helix, and I think we saw Anne and Tim demonstrate this, and the challenges of this particular juncture in life is I like to think of that when I'm looking after someone with dementia, we're making a diagnosis of dementia, that I'm working with what we call a dyad, with 2 people, because that's a reality. There are usually actually could be a lot more than 2, because the family support can be pretty wide. But I imagine this is this relationship being a bit like what we call the double helix. You remember and there's a sort of a genetic connection here, which is quite fun. But it's about this turning of that double helix around. So as you look at it, at the early stages with the person who has some cognitive difficulties in a family member, do you see the person with cognitive difficulties is at the front of the whole discussion? But as you go down through time, there's a point where, in fact, the family member and the person with now dementia is about equals, and that at some point later on, there has to be a turnaround where, in fact, the family member has to take precedence in decision-making over the person with dementia. When? It's a really vexed question. And I don't think it's necessarily at one time point for everything. It's clearly not. There are times when people can make a decision and they're happy to make that decision. It's safe for them to make that decision. But one of the things I find in practice is that I often need to provide my carers with advice as to when. We need to be permissioned sometimes to take those decisions. And often I find that it's very difficult for families and a family member to take over. They don't want to. It's really challenging to do that. And I think that's one of the times when people can feel very lonely as a carer, because they're not quite sure what to do. So I think if you feel like that, then speak to your doctor, and I think the idea of the Nightingale nurses are amazing. But also there's opportunities in primary care to try and provide with that support. And this comes back to this question of timely diagnosis. When is the right time to make a diagnosis? And there isn't really a right time. People talk about early diagnosis. I don't actually like the term early diagnosis. Because I don't think early is right. It's timely, I think, is the way I like to think about it. And Julian Hughes, who was invited out to Australia by Alzheimer's National, described it like this: a diagnosis is likely to be timely at the point where the cognitive and other changes that people are experiencing begin to affect their lives and the lives of those close to them. I think that's the time we should be starting to make a diagnosis. And for some, that will be when there's mild cognitive impairment, and for others, it'll be when there's dementia. And what we do know is that screening the whole population is not useful. So there is no recommendation for screening of the whole population for cognitive impairment, because we don't have screening tests that are useful. But what we do know is that it's very important. And again, it was fantastic to have Anne speaking first, because she's able to just reinforce or demonstrate this in real terms, how important early diagnosis really is. And it does a couple of things. It helps people with dementia, and we've talked a bit about that, reducing stress and anxiety. Why? Why would someone who has got early change without a diagnosis be stressed? Quite obviously, they don't know why things are going wrong. And if you can actually provide an explanation as to why I can't remember those things, why did I forget my son's birthday? Why was I not able to remember the bus trip and manage what I usually do at home? And why did I get frightened when I travelled overseas? I mean, the brain is a pretty simple beast, isn't it? I mean, people like to think the brain's complicated. It's not. What's the brain do? It just tells us who we are, where we are, and what we're going to do next. Does it do anything else for us? I don't think so. Because is there any time where you have been comfortable when you haven't known who you are? No. Nobody's comfortable not knowing who they are. And what do you would go looking? We don't like that. What about what you're going to do? What about where you are? How many people have travelled overseas? Okay. What did you do before you travelled overseas? Looked up a map, made sure you knew where you were going, got a bit of a plan, and then you arrive in a foreign country, and the first thing you want to do is make sure that you get picked up by the taxi man who's actually approved by the hotel, because you need to know you're going to get to the hotel. You're never going to want to not know where you are in that sort of environment, and particularly in places like Thailand or in Arab countries where in fact the whole language is completely different. You can't even read a sign. What about what you're going to do next? Are we ever comfortable not knowing what we're going to do next? I don't think we are, but we pay big money to do that. How many people have paid to go to an island off Thailand just to sit on the island and do nothing? We all have. Because you know what? We absolutely love the idea where it's secure, that we can choose not to do anything, but we actually don't have to make any decisions at all. We actually take a holiday, we don't have to make decisions. But if you actually don't want to be like that, and you still don't know where you are or what you're going to do next, you go looking. You go seeking that information. So not surprisingly, there's a lot of repetitive questioning that happens at times in families where there's cognitive impairment, because there's this anxiety about what am I going to do next? Oh, hang on, we were going somewhere. Darling, what are we doing next? We've got the hairdresser? No, that's tomorrow. Oh, okay. And so this sort of repetitive questioning happens. But in addition to that, it gives opportunity for control, this early diagnosis. But it also maximises the opportunity for preventative treatments. And going back to this concept of prevention, there are particularly in patients who have got vascular causes for their change, then managing high blood pressure, managing cholesterol, using aspirin can actually prevent progression of that problem. And it also helps families by confirming and conceptualising concerns, and it certainly helps health systems and community systems work. Because if we know that someone's got problems with cognition, then we can bring the systems to help, and certainly that's useful in, oops, I've gone the wrong way, useful in hospitals. I'm going to briefly, I know that time's running away from me by the second here. So I just really wanted to, I'm going to whip through this until someone else wants to know. No, I don't. I want to talk about this, because this is important. So I wanted to just briefly comment about the concepts of where we're going in research. People have asked me about what's happening and we're going to get a lot more from Ron about the science of this, but just to get back to it, this concept of when do we have the diagnosis and when do we not have the diagnosis is quite important, because we're now in a position to know that amyloid, which we think is the major cause of memory and thinking difficulties, is accumulating well before we have any symptoms of memory and thinking difficulty. So that's going to provide a window for opportunity, and I think many of you would have heard about a new antibody called aducanumab. I had to sit down and think about that and say that 4 times before I could say it properly. But this is a new antibody against amyloid, and the amyloid plaques are here, for about tau, and what happens in Alzheimer's disease, obviously that's a nice juicy brain in the top, and if you see down at the bottom, there's a lot of gaps between the various folds of brain tissue, and that's where there's atrophy. This particular patient here is a patient I had, and he had frontal dementia, and you can see at the front of the brain there's a lot of atrophy, and his CT scan looks like this, where the black is liquid and the grey is brain tissue. So there's a lot of extra liquid and not much brain tissue, and that's a specific abnormality of frontal disease. So I just wanted to mention this because some people have asked to me about how does amyloid accumulate, and if you look at the top, you start with amyloid precursor protein, and that's a very important protein in the brain, but there's 2 ways we can digest that protein. We need to turn it over a lot, and there's a good way which uses alpha secretase, which is, I'd like to think of secretase as being a pair of scissors. So you cut this particular protein. If you can see that, if you look at in the good direction, it cuts A beta in half. And if you cut A beta in half, you can't accumulate beta amyloid. But if it gets cut by 2 not so good scissors, beta secretase and gamma secretase, which are the other to go the other way, what you do is you get left with A beta, and then that accumulates in the brain. And there's a lot of work being done both at trying to stop it being cut in a bad way, but also helping digest A beta once it's accumulated, because there is a population of people who accumulate amyloid and never get Alzheimer's disease. And aducanumab was derived from some of those patients thinking that there might have been an antibody in them that actually stopped the process of dementia in the setting of amyloid. And this is the holy grail of all that. This is a lot of statistics, but if we took at this is talking about the age-specific incidence rate. So the ASIR is the age-specific incidence rate. Incidence is the number of new cases each year. And if we've got a lot of new cases happening and you can live for 8 to 10 years with a dementia, then you get a lot of people with dementia in the community. So if we can actually reduce the age-specific incident rate by 20%, which means delaying the onset by 19 months, then in fact, by the time we get to 2050, there'll be 44,000 people less with Alzheimer's disease in the community. So that's why we spend a lot of time and we want a lot of money in research to try and change outcomes. Fossey's back, thank goodness for that. That's to remind me that I've only got 5 minutes left. I just briefly want to talk about a response that we've had nationally around dementia, and that's dementia care in hospitals. This is a program that I'm involved with. And these are quotes, and one of them is a lovely quote with aphasia, but I kept on forgetting those, those round things. Anyway, sometimes they got cross with me. And there's 2 other quotes from carers there. The concept that we would get cross with a patient because they have a disability, which is dementia or cognitive impairment, is to me an embarrassment. But these were quotes from people back in 2004 when we began our program with dementia and cognitive impairment in our hospitals. And what we do know about people with cognitive impairment and dementia in hospitals is that their risk of developing urinary tract infection, pressure ulcers, pneumonia and delirium is substantially higher than those who don't have cognitive impairment or dementia. And that is matched for their age, for all the other conditions they've got. So just because they've got cognitive impairment, they have these increased risks, which cost the hospital a lot, but causes a lot of pain and discomfort for people with dementia and cognitive impairment in hospitals. And what we do know about hospitals is this, that we're very rarely, or we're very poor at identifying people with memory and thinking difficulties in a hospital. And so in fact, nurses are much better than doctors are at picking this, which is not surprising because they're better full stop. This program is developed, I've worked with two or three fabulous nurses who I still are working with 10 years later, and I all credit to them and their observations in the hospital. But what has really become very clear to us is to have meaningful change if we're going to care for people with cognitive impairment, is that we actually have to change the care paradigm in hospitals. And from one where the patient is expected to respond to the demands of the hospital environment, to one where the staff need to change their own behaviour and change the hospital environment that is appropriate to the cognitive performance of the patient. This is a fundamental change in thinking. There is somewhere in hospitals where this happens. Does anybody imagine where there is one ward in every hospital where this has been done? Paediatrics. Who said that? Who's the smart person who said, hand up in there, fantastic. It's true. We've completely changed the geographic and the systems of care in paediatrics to help a patient population with cognitive impairment. Emerging cognitive performance, but ultimately cognitive impairment. Kids cry when their mum leaves. Why? Because there's no cognitive anchor for them. They are frightened. Older people with dementia call out, Mary, Mary, when their Mary leaves, because there is no cognitive anchor. If we don't address that, then we won't be able to manage and support people with cognitive impairment in hospitals. And so to achieve this, we felt in Ballarat, at least in 2004, we need a screening program, we need a structured hospital-wide education program, and it needs to be linked to a cognitive impairment alert. And so we've run this program, and we're very fortunate to have worked here in Adelaide with the Queen Elizabeth Hospital, who has taken up the Dementia Care in Hospitals program, which has now just been launched to the Royal Adelaide as well on the 12th of September. And this alert now has been endorsed by Alzheimer's National as a symbol for cognitive impairment in hospitals, and we're working through the processes to get that more formally arranged. And I think this is fabulous because this means that then we as a hospital have to be aware of the needs for a patient with cognitive impairment, and we admit that we're going to change, or we're going to commit to changing the way we do things for patients with cognitive impairment. And I think this is a great way to go. Yes? They'll be up on the website. The cognitive impairment identifier you'll see is trademarked because we want to know that if it's going to be used, it'll be used to change the culture of the organisation it's used in. The only reason we had permission to use this in hospitals is because people with dementia and their families said, yeah, you can use a symbol to say my brain's not so good in the hospital. There are a few taboos around that. But ultimately, they said, yeah, do that so long as you change the way the organisation works. So we've trademarked this because we want to ensure that if a hospital uses this, they change their culture. They change their culture so they support people with cognitive impairment and with good communication and involve carers. And I think this is a step towards making sure that people aren't alone and that we change the way hospitals work so they're more dementia friendly. And in fact, in a community level, there's another way of looking at symbols, which is actually equally exciting, and I think some work has been done by Alzheimer's around this, is the idea that in fact an organisation like maybe Centrelink or a bank could actually train its staff so that if they had trained staff available, there would be a symbol on the entrance to that particular premises to say, we have someone here, if you wish to take up that offer, we have someone here who could assist you. And I have a vision of one day when I go to Myers or David Jones, there'll be a whole series of the pay desk here. You know, they have little cards, which is the Visa card, Diners Club, American Express. There'll be the Alzheimer's Association's dementia-friendly card, because at that moment, the person at that desk is fully trained to support people with cognitive impairment if that person wishes to say, I would like that assistance. It's very empowering for the individual and their families, and it means that you don't get that sort of fear or frustration that can often occur, which is completely different, I love this, completely different to the symbol we use in hospitals, because in hospitals we're using the symbol for everyone who we screen for cognitive impairment, but that's to tell us we have to respond differently as a hospital in order to support that person. So I clearly need to stop, and I'm going to stop right here, but with this last quote from people with person with cognitive impairment, I didn't want them to make a fuss of me. There were people worse off than me. I may forget some things, but I'm not stupid. And I think that that's what we would like to think for all people with dementia and cognitive impairment, both in the community and in hospitals. Thank you very much.